Okay, class, welcome to the last snippet here for cardiomyopathies. So here is my lovely drawing that was way fun. This is here you have a normal heart, okay? Now I had flipped it backwards, to this, okay, being the left side, and this being, the right side. As if you're looking at it that way. But it doesn't matter. I just really need this for an illustration. So here you have a normal heart. Here is what you have a hypertrophic heart. So I want you to kind of take note. What is happening is that it cannot really increase the stroke volume or the contraction, because look at what happens is that, look at, here's a normal right ventricular inside, and look what happens to this right ventricle here, right? The ventricles actually get smaller due to some sort of genetic abnormality. Now, the clinical course is variable, but look at what happens as you work harder and harder, because of increased demand. Look at this is right here, this is the muscle wall, okay, of the ventricle. So I'm just using one ventricle to just illustrate what's happening. Is look at how much this muscle wall and this muscle wall actually gets bigger. And so as the heart muscles work harder, the cells get bigger, the ventricles thicken, okay? And what happens is that you have to know, as it gets thicker and thicker, you can actually affect, this septum, that divides the two ventricles, and so as it gets thicker and thicker, it can actually push up and actually affect the valves. And as you can imagine, as they work harder and harder, initially they might be okay for a very short time. Eventually they'll have, shortness of breath, chest pain, decreased exercise tolerance, and possibly even sudden cardiac death, because as they get harder, they can actually have, anytime the chamber enlarges, they're always at risk for some sort of arrhythmia. And so you have to understand that what is really happening anatomically and physiologically, what happens with this particular part. And so, you can have non-obstructive, but the muscle wall can get bigger, where it actually obstructs. It can get bigger and bigger until the point where the inside this ventricle is so small, it can actually, the muscle obstruct the valves. And since it gets smaller, you hold less blood, you will have to work harder, it raises their blood pressure, right? Now versus here you have dilated, and you can see, look at normal, look at hypertrophic, look at dilated, right? So you're talking about now the muscle actually dilates out, okay, the actual chamber. So look how big this gets, right? Somebody could have had coronary artery disease, alcohol toxicity, pregnancy, or some sort of inflammatory process. But what happens is that, it usually manifests itself in some sort of like heart failure type symptoms. They all do, because cardiomyopathy eventually all end up in like heart failure symptoms, pretty much progressively. That's really what happened. This is probably the most common, occurring in adults like 20 to 60. It affects the ventricles, and the atria. But what happens is it typically starts in the left ventricle. And I know I'm showing you, I just needed you can call this the left ventricle. I free drew copying a picture, and they had the direction flipped that way. So you can look at this as like the left ventricle or not, but it typically starts in the left ventricle, and as it begins to dilate, it stretches, and like the walls get, thinner and thinner, okay, and the ventricle actually enlarges. So the problem eventually is, okay, it spills over to the other ventricle, but the problem is as you dilate, it doesn't contract normally, right? So imagine like you've stretched out this ventricle, and how the heck are you going to dilate? You can't exactly pump well, so they're going to have symptoms of heart failure. It can eventually also lead to valve issues, as well as dysrhythmias, cardiac conduction issues, leading to sudden cardiac death and or blood clots. Okay, last you had this restrictive picture, and so this is not something I can technically draw. This is the rarest form, okay, because what you can't see is here, what happens, the ventricle walls, it says restrictive, and this becomes stiff. Okay, so what happens is that you have abnormal deposits of amyloid protein, and so you can imagine like this is really not going to be good over time, because if you deposit everything along the ventricle wall and it becomes stiff, well, your ventricle, like depending on what it actually impacts, is not going to be able to relax. Okay, so if you're not going to be able to relax, you're not going to be able to actually fill, during diastole or during, at the relaxation state. So it becomes stiff and rigid and non-competent, and so over time, again, you're also going to have symptoms of heart failure as well. They'll get short of breath, they'll have activity intolerance. That's all a commonality among all the cardiomyopathies. I want you to think heart failure. And so again, this is the rarest form, dilated the most common because you're stretching them, and then hypertrophic and you're working harder and harder. And this concludes cardiomyopathy. Thank you.